Hello, welcome to my channel again, and today we are going to do the respiratory systems pharmacology. And this video, subscribe and please join us till the end. Okay, so we are going to start with the respiratory pharmacology with the topic of asthma. So we know that what asthma is, and I'm going to be posting videos about what asthma is later on. But first of all, we are going to study about the various kinds of drug that we take during asthma. So I have divided the type of drugs into three categories. The first would be anti-inflammatory drugs, and the second would be autonomic drugs, and this third category would be miscellaneous drugs. So in anti-inflammatory drugs and in autonomic drugs and miscellaneous drugs, let's see what we include in these drugs as well. Because you know that asthma is a process that is related with bronchial hyperactivity. Anti-inflammatory drugs help reduce the hyperactive part. Autonomic drugs help in reducing the tone of the bronchial muscles, and other drugs that also help in the process. So, first of all, we have anti-inflammatory drugs. We know that anti-inflammatory drugs are of two types. They are NSAIDs, non-steroidal anti-inflammatory drugs, and they are steroids, right? So, first drug we have is steroids. Inhaled steroids is first line treatment of asthma, and we can see that inhaled steroids, these corticosteroids inhibit the phospholipase 2, as we studied in the inflammation in the inflammation module, that phospholipase 2 converts phospholipids into arachidonic acid, and this steroids prevent this from happening. Now from arachidonic acid, 5-lipoxygenase converted into leukotrienes, and these anti-leukotriene drugs inhibit the formation of leukotrienes. There are two types of anti-leukotriene drugs as we speak. Sorry, I missed the steroids mechanism of action. They inhibit the NF-κ beta pathway. As a result, it inhibits all the inflammatory mediators and thus reduces inflammation. Although it produces oral thrush, and that has to be prevented by taking saltwater gargles. And then we have anti-leukotriene drugs. Anti-leukotriene drugs, I've already explained the mechanism. There are of two types. First of all are the 5-lipoxygenase inhibitors, as we've discussed, and the other one are leukotriene receptor inhibitors. In leukotriene receptor inhibitors are I'll tell you the names of these as well. So 5-lipoxygenase inhibitors include Xilotron, and the other one are montelukast. We have to understand this suffix, which is important. Okay, leucast suffix, as these drugs are basically the leukotriene receptor blockers. Okay, these drugs are leukotriene receptor blockers, and these drugs are 5-lipoxygenase inhibitors. I should have written them in the other order. Okay, the next drug we have is anti-IgE. We know in asthma there is a lot of IgE. So those kind of drugs which bind to IgE, binding portion, the part of IgE that binds to mast cells, these antibodies bind this part. Say this is another antibody. Okay, this is anti-IgE antibody, monoclonal IgE antibody. They bind to this part and they prevent it from binding the mast cells, and thereby preventing the mast cell degranulation. So these drugs, the name of this monoclonal antibody is omalizumab. Okay, it is used in highly resistant asthma that has not been treated by steroids or autonomic drugs. And then we have this anti-interleukin 5. We know that interleukin 5 is the one that is going to activate and bring all the eosinophils to the party. So we have two kinds of anti-monoclonal antibodies. One that that are directly against interleukin 5, and the other ones that are against the interleukin 5 receptor alpha part of it. Receptor alpha 1. Okay, and these are meprolizumab and reslizumab, and the other one is benralizumab. Okay, now we have the other drugs that are used in asthma are autonomic drugs. Autonomic drugs, we have to understand that there are beta agonist drugs and muscarinic antagonist drugs. Okay, we tend to confuse between these two, right? So beta 2 agonists are of two types. All right, We know that bronchial smooth muscles have beta agonist, they have beta receptors, beta 2 receptors, and they respond with an agonist. When an agonist is given, they cause relaxation of the bronchial smooth muscles. So we have a short acting one, and we have short acting ones and we have long acting ones. So in short acting ones are given in acute bouts of asthma, but as long acting ones are given for the long term therapy. There are albuterol, which includes and these beta agonists are in the first line therapy of asthma as well. And long acting ones include salmeterol, salm, and formoterol, right? Okay, and then we have the muscarinic antagonist. Okay, we are studying these names from quite a while now. These are ipratropium and tiotropium, right? Okay, so these are the drugs, right? And obviously these are beta agonist drugs, and they have all of their beta agonist side effects like tremors and arrhythmias, and the muscarinic antagonist as well. They bring with them all of their respective uh, problems that are related to these drugs. Okay, the last one of these asthma drugs is the miscellaneous drugs. These are chromones, and they prevent mast cell degranulation. Mast cell degranulation, as we know that sodium promoline, that when Ig antibody binds to its particular receptor, and FcR1 receptor, it causes the degranulation of mast cells. So these are the compounds that cause the stop the degranulation. And then we have the methylxanthines. Methylxanthines are basically phosphodiesterase inhibitors. They prevent the cyclic AMP. Basically, phosphodiesterase, what does this enzyme do? It causes the inactivation of the cyclic AMP. So it prevents the cyclic. So this inhibitor, if we give this inhibitor, phosphodiesterase does the inhibition of cyclic AMP. This is a very normal process. But if we give this inhibitor, it's not going to let this process happen. And the cyclic AMP is going to be in abundance, and it is going to cause relaxation of the bronchial smooth muscle. Relaxation of bronchial smooth muscles. That's it. Oh, smooth muscles. Okay. The next thing we have is the drugs for the pulmonary hypertension. Okay, first of all, we have prostacyclin analogs, and I have to tell you the names of these. You have to remember this: epoprostenol, EPO1, and ILO1. EPO and ILO are I2 prostaglandins, and they help have a bronchial the vasculature. They have a pulmonary vasculature relaxation effect. Along with that, they are also helpful. They relax smooth muscles, and they also cause platelet aggregation. They platelet aggregation prevention. They don't let this happen as well. However, they have a very weird side effect. They cause jaw pain, jaw pain. And as they're vasodilators, they cause flushing, okay? The other drug we have phosphodiesterase 5 inhibitors. Alright, phosphodiesterase 5 inhibitors, what do they do? Okay, I forgot to tell you something about the phosphodiesterase 3,4. They have a very unique, relationship with adenosine. Okay, you cannot give both of them simultaneously because this will cancel out the effect of this. And they also cause cardiotoxicity and neurotoxicity. And okay, let's come back to phosphodiesterase 5. Phosphodiesterase 5 inhibitors are those because we studied the cyclic AMP ones, but they are going to be increasing cyclic GMP, thus causing relaxation of the vessels and vasodilation, okay, in helping in the pulmonary hypertension. Again, endothelin receptor antagonist. Endothelin is itself a very endothelin 1 receptor. Endothelin is a vasoconstrictor, so endothelin receptor antagonists are going to do vasodilation. Okay, so this is bosentan. Okay, you have to remember this. Bosentan is the name of this drug, whereas phosphodiesterase 5 inhibitors are very important. Generally, apart from pulmonary hypertension, they are used in erectile dysfunction, and you cannot give erectile dysfunction drugs along with the pulmonary hypertension drugs because both of them will have an additive effect and ultimately result in hypertension, and the patient will suffer because of this. Lastly, we have cough and cold medication. We have antihistamine drugs. Antihistamine drugs are of two generations. The first generation, which all have which are like diphenhydramine, chlorpheniramine, and dimenhydrinate, diphenhydramine, etc. They are usually used for vomiting related because they are CNS acting. So vomiting related, like motion sickness or pregnancy related sickness, they are given, and they cause sedation. They cause a lot of sedation, therefore they're not given. And they have a lot of anti-alpha effects, anti-alpha and anti-muscarinic effects. That is why they are usually avoided. It can cause hypotension, it can cause constipation, urinary retention, and neurological disturbances as well in a person. And in second generation are usually used these days, like say like fexofenadine, loratadine, etc., right? Cetirizine. They are the ones that are given in cold and cough medications and allergies, and they cause minimal sedation as compared to first generation antihistamines, and they're antihistamine 1 inhibitors, H1 blockers. Then we have antitussives. Antitussives are dextromethorphan, and it is a type of opioid. Methorphan, okay. It is a type of opioid. It has a very mild abuse potential, therefore it is safe, and you can overcome its toxicity with the help of naloxone, as it is an opioid as well. But you know what, you have to this would be like something different, that it is an NMDA glutamate receptor antagonist. And finally, we have medications for the runny nose. Okay, we give vasoconstrictors for runny nose. Okay, vasoconstrictors for runny nose. And we have this pseudoephedrine. We have pseudoephedrine and phenylephrine, which oral alpha blockers, and the phenylephrine. Oh my god. Okay, phenylephrine. These are all alpha blockers. But a very important correlate with these medications is rhinitis medicamentosa. It is a kind of a refractory rhinitis that occurs after you take these medication, because it will cause erythema, and again the runny nose process will start once you discontinue these medications. So you can take them, but max up to 6 days. After 6 days, rhinitis medicamentosa will be your result of your patient. And that is it for today.